First of all, thank you very much for the invitation. My name is Johannes Schetelig. I'm the head of the cell therapy unit at the Technical University of Dresden, and at the same time, I have the privilege to chair the clinical trials unit of DKMS. We reported again and discussed data from the ASAP trial. This was a large randomized trial addressing patients with relapsed AML, first untreated relapse, or a poor response after first induction chemotherapy. But let me first give a little bit of background information. When we attempt to induce a complete remission prior to transplantation, this is standard practice. It is what is written in textbooks. But what some might not know is that there has never been conducted a randomized controlled trial in order to demonstrate that patients really benefit from an attempt to induce a complete remission prior to transplantation. What we are doing is mainly based on conceptual thinking. And even if you look for registry data, so data which had been consistently collected from all patients for whom transplantation was considered at one point in time during their course of the disease, and then follow these patients throughout their history, this data is lacking. So we do not completely understand what we do and how we select patients when we restrict transplantation to patients in complete remission. This is the background against which we conducted the ASAP trial. In the ASAP trial, we aimed at demonstrating non-inferiority of an experimental arm. And this experimental arm consisted of offering immediate transplantation as soon as possible, which gave the name of the study, preferentially after a period of watchful waiting only. There was the possibility to offer anti-leukemic treatment with approved options. At that time, it was low-dose Cytarabine and single doses of Mitoxantrone. In the standard arm, we offered high-dose Cytarabine-based salvage chemotherapy. The salvage regimen consisted of high-dose Cytarabine combined with Mitoxantrone. The result of the study and the primary endpoint was to have achieved a complete remission after transplantation. And we took information from day 56 after transplantation for all patients. When we look at this endpoint, we found high success rates, so high rates of complete remission after transplantation on day 56 in both study arms, with a slightly higher rate in the experimental arm. However, we failed to demonstrate non-inferiority with a 5% benchmark. However, what we do have is a nice confidence interval and an estimate for the success rate with both strategies. And the result of the study was that we had a 3.4% higher complete response rate or treatment success rate with the experimental arm compared to the control arm. And we have a confidence interval ranging from minus 5.8%, so touching the non-inferiority margin of 5%, but also an upper margin of 12.6%, indicating that there is a possibility that the strategy is even better than standard care. The treatment success rate in the disease control arm was 83.5% compared to 81% in the remission control arm. When we looked at overall survival in the intention to treat population, analyzed according to an intention to treat from randomization, we saw no difference in terms of overall survival between the two options of treatment approaches. So the consequences of this trial are, and especially against the background of a poorly defined standard practice, is that patients may be informed about the possibility to proceed to allogeneic transplantation immediately without attempting to induce a complete remission prior to transplantation. And this may, of course, reduce time in hospital, expenses, but also exposure to chemotherapy. And the reason why we can drop this treatment step is that we can compensate for residual leukemia with intensive conditioning regimens prior to transplantation. In the talk at EBMT, I addressed a second issue, and this question was rather related to the level of residual disease for patients in complete remission. This is mainly referring to work which has been conducted in the past 3 to 4 years. When we initially investigated the impact of minimal residual disease in complete remission prior to transplantation, there was an indication that this is a major risk factor for outcome after allogeneic transplantation. However, more recent studies, which carefully adjusted for the AML biology and the risk profile of the patient, did not indicate this difference anymore. And these are studies coming from a variety of different research groups across the world. A group from the Dana-Farber Cancer Institute published data in 2022. First author was Dr. Murdoch. The Hanover group presented data at last year's ASH 2023, presented by Dr. Bader at last year's ASH. The HOVON presented data which indicated that TP53 mutations detected prior to transplantation at a residual molecular level did not predict outcome in CR1. And also researchers from the Fred Hutch Cancer Research Institute published in 2020 by Dr. Morsink did not show an impact of residual disease defined by for patients with monosomal karyotypes. So right now we do have to question the importance of this risk factor. Maybe the importance is much smaller than we initially anticipated, when perhaps mostly those patients who had MRD positive disease represented a subgroup of patients with more aggressive AML biology. So when I said that salvage chemotherapy may not be needed for some patients, one has to ask who needs still salvage chemotherapy in 2024. And I can share that it is standard practice at our center to offer gilteritinib or any other approved FLT3 inhibitor for patients with FLT3 ITD or TKD. And the reason why we do this is that this drug has a very beneficial risk-benefit ratio. So it is well tolerated. Patients stay out of the hospital. You gain disease control in many patients, and which is an important feature, you can continue with this drug after hematopoietic engraftment and successful transplantation, which again might improve outcome after transplantation. A second group of patients who do need immediate salvage chemotherapy are those with hyperproliferative AML, those with very high leukocyte counts, who are at risk of leukostasis. They definitely need salvage chemotherapy, and there's no way to offer transplantation right away. Same for patients who have complications already from AML, and those patients for whom a donor is not readily available. So all these are patients where you have to consider to give salvage chemotherapy or any other potent treatment in order to gain disease control prior to transplantation, or optimally achieve a remission. Achieving a remission is never something bad for a patient. It just is often something good, but it doesn't apparently change the prognosis after transplantation. It doesn't matter that much. What matters is disease biology, not the level of residual disease prior to transplantation. This is at least our interpretation of the data. Finally, I would like to say that much more research has to be done on this topic. We have to identify those patients who benefit most from this ASAP transplant strategy in terms of AML biology and physical performance. And we need a much higher level of evidence for making smart choices for conditioning regimens reflecting residual levels of disease and in reflection of the specific disease biology of the disease which we want to cure. And finally, and most important, what we do need is maintenance therapy after transplantation in order to improve outcome of those patients with very high-risk disease.